Our greatest weakness lies in giving up. Welcome to the Guyana Dialogue. I'm your host, Shamiza Ali. Our topic tonight is how Northwell is helping to modernize healthcare delivery in Guyana. The Guyana Dialogue is being sponsored by a coordinating council of Guyanese based in the US, UK, Canada, the Caribbean, and Guyana. Funding support is by well-known philanthropist Dave Narayan from Dave West Indian Imports. Please welcome my moderator for tonight, Dr. Tara Singh.
Thank you very much, Shamiz, and welcome to our viewers. Welcome to
Dr.
the
Tara.
Italians and welcome to Dr. Pino.
My panelists tonight and moderators are Professor Muniram Budu and Dr. Ganga Ramdas.
Hello.
Good evening.
Good evening to you.
Dr. Ganga will join us shortly. Our guest tonight is the president of the Center for Global Health, Northwell Health, Dr. Eric Cioe-Pena.
Hi, pleasure to be here. Thank you.
And Dr. Cioe-Pena is the founder and current vice president of the Center for Global Health of Northwell Health and Zucker School of Medicine at Hofstra, Northwell. And he's also an associate professor of emergency medicine. He is a graduate of SUNY Dong State Emergency Medicine Residency Program and the Columbia University International Emergency Medicine Fellowship. He received a master's in public health and humanitarian assistance from the Columbia University Mailman School of Public Health and received his Doctor of Medicine with a concentration in global health from the University of Pennsylvania. He received his MBA at Hofstra University. He served as a ACEP lead ambassador to El Salvador for over a decade. He has worked extensively in Ecuador, Guyana, India, Ukraine, Botswana, Dominican Republic, and El Salvador on health system development projects, trauma care, and humanitarian assistance. Dr. Pena is a fellow of the Health Management Academy and American College of Emergency Physicians. In January, he received the Schwab Foundation 2025 Corporate Social Innovator of the Year at the World Economic Forum in Davos, Switzerland. Dr. Pena is the leading global initiatives at Northwell and Hofstra with specific focus on stakeholder-led projects centered on access to global mental health, global surgery, and utilization of technology close to health equity gaps globally, as well as to mitigate the effects of climate change on global health. Dr. Pena was redeployed in 2020 and 2021 with Northwell at a 108-bed COVID alternate care facility in conjunction with the state of New York as the medical director, where he directed the care of over 1,000 COVID patients. He is the past president of the Global Emergency Medicine Academy of the Society for Academic Emergency Medicine, and he is also the past president of the Global Emergency Medicine Fellowship Consortium. He served at the Public Health and Injury Prevention Committee. He has met and been recognized for his work in global health by Prime Minister Mia Mottley of Barbados, President Mohammed Irfan Ali in Guyana, and President Zelensky of Ukraine. Thank you. Dr. Tara, please go ahead.
Thank you very much, Shamiza. Our viewers will listen to that very impressive resume by Dr. Pena. Of course, he's a distinguished administrator as well as a doctor of medicine, and he has functioned in so many areas. I know he's very intimately connected with Guyana as well, and we'll get into that. But just before I ask Dr. Pena to comment on something. I read a report today in Starbuck News where they suggested there is an outbreak of fever. But I think that more or less sensationalized it. Dengue was an ongoing thing, but not so rampant. Last year they had about 10,000 cases, and most of the regions affected are probably the interior areas, riverine areas, region 1, region 7, region 8, and region 9. There are some cases in region 6, which is quarantine. Um, Dr. Pina, I don't know, I know you have expertise in various areas, but I don't know if you're aware of this dengue situation in Guyana. If you can just comment on that, because it seems to have a lot of public attention now.
Yeah, no, I certainly, as a global health practitioner, have a lot of familiarity with dengue. Dengue is one of those vector-borne diseases, mosquito-borne diseases that is continuing to expand worldwide. We have been registering more and more cases in the southern part of the United States, in addition to also malaria coming back to Florida and some areas of southern Texas, and it really is a problem that the world has to deal with. These mosquitoes, we know how to control them. We know how to prevent this. It's really about rolling out effective programs. And unfortunately, mosquitoes don't follow, like infectious disease, and mosquitoes don't follow international borders. And so it really needs to be a region-wide initiative. This is one of the reasons why when we interact with the Pan American Health Organization and even the United States Southern Command, Southcom, that has a global health security division. These are things that we talk about because this is really a regional issue, and the region is getting bigger and bigger as climate change makes the planet warmer and warmer. The region where these mosquitoes are endemic and this virus can hide is getting bigger and bigger.
I want to ask you first, can you tell us what make you get interested in work in the Caribbean, like Barbados, Guyana? I don't know if you work in other Caribbean countries, but tell us what motivated you or excited you to go and work in Guyana.
It's I've always been passionate about global health since I graduated from medical school. Even before medical school, I was very passionate about the inequity in the world and working with global communities to solve big problems. I think what attracted me to the Caribbean, to Guyana specifically, are the people that I work with at Northwell and the community that I work in. Shamiza mentioned during my training, I trained in Kings County Hospital in SUNY Downstate for emergency medicine training. So, the West Indian population and the Caribbean population have always been kind of part of not only kind of the global community, but also my local context. I would take care of patients in the emergency department. I would work with colleagues who were from Barbados, from Guyana, from Jamaica, that still had ties back home. And so when we were thinking about, as a health system, where we were going to get involved, when I first came in 2018, Northwell was involved moderately in 37 different countries. And the task that I was given was, how do we really focus our efforts on a few countries so that we can really make a difference, so that we're not just there for a couple of weeks and then gone. And so when we were narrowing that list down, one of the big criteria we used was, how much of a local connection to the country do we have? And with Guyana, it was obvious. Richmond Hill is in Northwell's backyard. So the Guyanese diaspora is our community. It makes up our team member base and our patient base. And so Guyana was actually the easiest choice. Guyana was the country that, when we were selecting countries, it was kind of number one, and there really wasn't a lot of debate that it was going to be one of the core sites or the global health sites that we focus on. When we got into other countries, Ecuador, India, I think it was more robust debate. But for Guyana, it was really something, we had started in 2017 with the relationship with helping with radiology training, and we just kind of kept meeting and expanding that. First site visit was in 2019, right before the pandemic. Second site visit was during the pandemic, right in November of 2021, and we've just kind of expanded from there.
Dr. Tara, please go ahead.
Yeah. Pardon me?
Go ahead.
Yeah. Yeah, I understand. Thank you. Now, specifically, Guyana, in what areas of collaboration? I know recently the government announced mental health, a major mental health program that was, they were supposed to get some technical assistance from that from Columbia University, who I understand is doing a study into mental health, mental illness, including suicide. I don't know if you're aware of that, but your connection, has it got anything to do with mental health or just working and training people in various specialty areas or do analysis?
I mean,
Last year. Yeah.
Yeah, our primary focus really is when we came down in 2021, for the first initial site visit with, post-pandemic. It was kind of a reset site visit. We asked the government and we asked GPHC and we asked the physicians that we had known before the pandemic, who do you want us to bring down? And they named, I think, 5 specialties at the time. They wanted us to bring down orthopedic surgery, pathology, psychiatry, OBGYN, and general surgery. And we brought those leaders down. And the program's really expanded from there to now 15, maybe 17 different departments and service lines at Northwell that are engaged with their counterparts and colleagues in Guyana. And it's really, the relationship has evolved to what I always ask whenever I'm talking to, Mr. Rambaran, the CEO of GPHC, or the Minister Anthony, it's what do you need? What can we help you achieve? And I'm not saying that we can do everything. There are things that require additional resources or funding. There are things that we have to figure out. But we start with what the problems are. What are the headaches that keep Guyana doctors and Guyana healthcare leaders up at night? What gets them worried? And we start with those problems. So mental health was definitely one of them. We were introduced to the Columbia colleagues. They are doing a pretty large study on suicide reduction and intervention. We're trying to just supplement that. We're not doing that many studies. We're not doing kind of research. There's a lot of solutions that we think already are kind of proven that could work that just need to be implemented. And the rate limiting step often in Guyana is the number of trained people. You'll hear that over and over, that we need more nurses, we need more doctors, we need more paramedics and EMTs, we need more community health workers. And the ministry is using every resource it can to train folks. And so we're just trying to provide more resources so that we can do more trainings. And some of these trainings are really, really subspecialty. There are areas of psychiatry that only a few centers in the United States do. And so we've been really privileged to be able to partner with those departments to provide advanced training, which we believe it enhances the capacity of the doctors' training. And then, we do a lot of clinical exchanges. So our doctors are down there. And then when there are moments of crisis, like there was a mental health crisis point after the Madia fire, we had mental health teams in Madia, that week. We had sent people down at the request of the government to meet with folks, to have listening sessions, and to figure out what interventions were needed. So it's really it's a conversation. It's really about what do you need, how can we help make it happen, and a very honest and trusting dialogue. That if you ask me for something, I'm going to tell you if we can do it. There's things that we can do right away that don't cost the health system a lot of money, that we can do pretty quickly. And then there are things that they're big. We got to work on finding funding together, or we need to unlock some other resources to make it happen. This is dangerous because
Okay.
I could talk forever. So you've got to, at some point, you've got to cut me off and let me.
Okay. I pass you on now to Professor Budu. I noticed we are joined now by Dr. Ganga Ramdas. Dr. Ramdas, welcome. Professor Budu, any clarification or any questions you have at this point for Dr. Pena?
Dr. Pena, what are the short-term and long-term goals for this healthcare initiative?
So the short-term goals are really the dialogue, like I said. The short-term goals are training gaps. One of the biggest ones that we're working with the government and working with GPHC and working with the ministry on is nursing. So nursing retention, recruitment, and education. The nursing assistant course and assisting with kind of having the other roles in the hospital that can help the RN kind of practice at the top of their license and do things that only an RN can do, and then have people working under that nurse to do things that other people can do that doesn't require the RN degree. But that's really the short term. It's a dialogue, and it's how do we solve some of these problems in healthcare. The long-term goal overall is for the relationship between Guyana and Northwell to fundamentally change, because we want to provide the training opportunities, the education opportunities, but really what we view is that Guyana, in short order, can become a very, very world-class kind of healthcare system, and then it's much more of a bilateral kind of equal exchange of research, ideas, faculty, cultural exchanges, things like that. We want this to be a very long relationship, but we understand that the part of this, the relationship and how Northwell is going to be useful will change as the healthcare system develops. And it is really, it may feel to people that are living it like it's not changing very much. But my first visit to Guyana was in 2019. We've been there since 2017. And I've noticed a lot of changes in the health sector. There's been a lot of progress, and it's encouraging. There's still a lot more work to be done, and we've got a lot more. We can't sit down and say we've done a good job. We've got to roll our sleeves up and keep going. But there's a lot of progress happening, and it's really exciting, honestly, as somebody who works in global health in multiple contexts, to see the momentum that's building and kind of use that to really kind of continue the development and continue the rollout of this healthcare system.
Is there any particular medical services, for example, cardiac services, that you're focusing on?
Yeah, so we are, and you may be referring to the announcement that we made in early April. We just accepted a gift from the Subraj Family Foundation, from the CEO of the Subraj family, which is Tony Subraj. They gave $1 million to cardiac training and care in both Little Guyana and Richmond Hill, and in Guyana. And so there is a focus on cardiovascular disease, and also other non-communicable diseases like stroke. So stroke and heart attack, which are major killers of people in Guyana, is a major focus. And tied into all of that, the problem is that once you start focusing on one thing and you start thinking about all the systems that make the healthcare change. So if I'm having a heart attack and I'm in Georgetown, like, I need good emergency care. I need a good ambulance to pick me up. I need an EMT that can take care of me. I need an emergency doctor to see me in the A&E and stabilize me. And then I need a cardiologist to provide the definitive treatment. We're not stopping at one part of the healthcare system. We recognize that in order for anyone, we could train the cardiologists, but in order for anyone to notice the change, you have to have, from the time you're having the heart attack until you get that artery ballooned open, everything in between needs to work. And so it's complicated. And so we're focusing on diseases, but we are not focusing on areas of the hospital. We're really, from the pre-hospital sector all the way through to definitive care, we're trying to provide solutions to all of those. And the good news is when you're as big as Northwell is, it's not distracting, right? Like, it's not me doing this, right? It's the cardiology team and the emergency medicine team and the CEMS team. And so when you've got, I always joke, I have 104,000 friends that work at Northwell that will help me with these projects. And so that's really the strength of kind of our partnership, is that it's different teams that are working on different parts of this all at once.
No, culture, geography, and living standards significantly influence the prevalence and severity, for example, of cardiac diseases. Do you agree with that? And if so, how are you addressing this for Guyana?
Yeah, I think that's a really good point. I think, there's obviously there's a genetic component, and we have to recognize that Afro-Caribbean and Indo-Caribbean genetics have worse cardiac disease than other genetic types. But compounded on top of that is that a lot of the education around diabetes and hypertension really isn't culturally aware. Like, you can't tell someone, don't eat rice, don't eat protein. That's not a successful that's not a successful intervention. You have to work with people and say, look, this is the healthiest way to cook this. This is the healthiest way to eat this meal, and really making sure that your education and what you're doing in the community actually is going to resonate, so that you can still have your curry, you can still have the rice. You just need to have modifications to the meal so that it's healthier for you. And I think that is really the challenge that's always been, is the people that are the loudest about this are the Guyanese cardiologists that work for Northwell, the Indian cardiologists that work for Northwell that have similar diets. They're the ones that are like, no, we can't go in and just say, don't eat white rice. We have to go in and provide culturally competent education and training. And that is, I think, a part of the missing link that we hope to do.
Yeah, because apart from what you're saying, the type of food, there's the high fat content, the high sodium, large portion size, and Guyanese or the Caribbean, we like to feast.
Yeah.
And another cultural problem here is the delay in seeking medical advice. And there's somewhat of a stigma associated in doing this. For example, I know my parents never really see a doctor until they came to the U.S., you see. So how are you addressing these kinds of things? You have to get community involvement. Is the government and you working hand in hand to get this done?
Yeah, I mean, to a certain extent we are. And the government has started doing training and using more community health workers and getting out into the communities. I think going upstream, and look, this is a problem that is not unique to Guyana. I mean, it is many countries are going into this this development stage where it's no longer a food scarcity that is the defining part of the society, right? We are living in abundance, and so we're living in caloric abundance. We've made our lives more sedentary. We're less likely to walk places. We're less likely to get cardiovascular exercise. And so these changes need to become part of the culture. And the only way to make them part of the culture, it's not, a guy from New York coming down and saying, right, walk more. It's the community recognizing the value of it, and working with the Guyana physicians that we're working with need to be the leads. It's not also about the American doctors coming down and somehow we're delivering better care or doing something better. It's partnering with the Guyanese physicians as the leaders, so that the community also feels more comfortable approaching the medical system there and seeking care. Because you're right, if you're sitting at home saying, oh, maybe the pain will go away, and you're not seeking care for your chest pain, there's usually warning signs to heart attacks and stroke that we ignore. So education about that and how it's preventable up until a point. And then once you cross that line, it's much harder to get heart muscle back or get your brain to work again, and make sure that we're preventing heart attacks and strokes and not just finding out about them too late. That's education. That's about being in the community and saying this message over and over.
Is this started or that is something in the planning stage?
So it's in the planning stage. I mean, the ministry is already doing a lot, and I don't want to discredit what they're doing, but we are looking to ramp up some of that in our new campaign, so that we're going to specifically target diabetes, hypertension, and smoking. And we're doing that in Little Guyana, in Richmond Hill, and we're doing that in Guyana and out in the communities in Guyana.
Yeah, but I think with Guyana become a high income country, what follows is things like obesity, depression, suicide. Those things are are well known in many countries who became high standard of living. So there's a major task in hand, uh, and to change people's mindset is going to be much more difficult than having surgery.
Yeah, no, I agree, and it's really there is no quick fix, but it's a combination of education, prevention, access to treatment. One of the ways that stigma decreases in public health in general is when treatment is easy to access. When you know you can go to your primary care doctor and talk about this, you're much more likely to do that. When going to the doctor is a hassle,
Yes.
it's you're less likely to do it.
Yeah. Yeah. Okay.
Okay, Shamisa, you want to take the short break now?
Yes, we will be right back after this message.
Okay, Dr. Ganga, welcome.
Okay.
Your question or any clarification for Dr. Pena?
Thank you, Dr. Pena. I appreciate your outline of your approach to Guyana's healthcare, and it was quite comprehensive in your outline. I would mention that I was with Dr. Tara at several of his clinics before we started on these online educational programs. And in his clinic, I was this front desk statistician. So at that time, I did identify 4 risk factors, but I think there are additional ones. And you mentioned hypertension, diabetes, and alongside smoking. But there was also the chronic respiratory, non-communicable type of problems that are faced by the population, and also some other related eye, dental, and skin care. So if you can elaborate on these, and then later I'll ask questions on behavioral risk factors and longevity, the official age for Guyanese longevity in Guyana, not in Richmond Hill, where my brother worked at the Jamaica hospital. Not that age span, but the Guyana currently. So later we'll talk about that. Let's get to the risk factors.
Yeah, I mean, in terms of risk factors, I think you mentioned the addition of chronic respiratory diseases, and that's again a non-communicable disease that we see increase in as the income status goes from a middle income country to a high income country. We see more and more, you see more allergic symptoms, you see more respiratory symptoms, more asthma as there's more development. And then with the obesity epidemic, you get this other part where you can get obstructive sleep apnea, which raises your risk for AFib, atrial fibrillation, which is a heart dysrhythmia, stroke, and pulmonary hypertension, which is another kind of chronic pulmonary disease. Yeah, I mean the reality is that all of these need, that we're working with 2 parts of the healthcare system. The tertiary care system, which is the subspecialty care, that's a focus. We're working with GPHC, and we've already trained a couple of subspecialist physicians that are not just trained in, for instance, OBGYN, but are trained in urogynecology. So they're a subspecialty of GYN, and doing more subspecialty training. Pulmonology is another one that I think would be appropriate to mention. Interventional cardiology. Those are important. Having that subspecialty care that can treat these conditions and guide management is very important. But even more important, or equally important at least, is that going upstream. Solving obesity will solve a lot of the downstream problems of this. Solving diabetes. Someone put in the chat just now, access to medications, access to test strips. Those things are very, very important. And preventing the heart attack, preventing the stroke, preventing the pulmonary disease comes down to primary care and health education. And that is another major push that we are teaming up with the Ministry of Health to do. And then the third component of this is, as you're developing it, you're not going to have enough health resources for the need. That's just the way it's going to be for a couple of years. So utilizing telemedicine and technology to make sure that we don't have to move patients around to get specialty input, so that the community worker that's working, in Region 6 can get on the phone and talk to a subspecialist cardiologist and get some advice on medication management, and get some advice on if something's not working, if the sugar's not being controlled, getting a family medicine doc from GPHC to talk to the community health worker about going to a different level of care and a different level of therapy. And then the third component of that, which was also mentioned in the chat, is making sure that you have reliable access to the medications. The medications are in stock and that they're provided. All of those components, if one breaks, you're not going to get the effect of that upstream prevention, right? So it's a complicated system to provide that primary care, but it's absolutely necessary. And in the end, will save the country money, because the money that you spend on preventing the heart attack and stroke is much, much cheaper, even when you do it 1,000 times to the one stroke, than taking care of a patient who's had a massive stroke. And so if you can prevent the massive strokes, it's always going to be more cost effective for a country to do that. And so we feel very, very strongly about primary care and preventative care, but in combination with training the tertiary care system to make sure that good treatment's available too. We don't want to do this thing that we did during the HIV epidemic back in the early 2000s, when we were thinking about treatment versus prevention. It's not an or, it's both. You got to do both. It's treatment of disease, prevention of disease. Hand in hand, they work better when you attack both.
Yeah, you mentioned two important, very, very important things. I wouldn't elaborate on sleep apnea, but more education is needed there. That's a life-saving area, that one.
Yeah.
And also in terms of preventative care, with the sugar estates, we used to have community centers where you had gyms and crafts and games that are associated with the community center activities. So that's something that might assist in the agenda for preventative care. I think you might want to comment on the essentials of that. I wouldn't get into diet right now and seed oils. That's there. You're at war with that industry there, the food industry. But most importantly, is what I had read somewhere, that the official longevity age is 66 years in Guyana. Can you comment on that and what we can do to raise it to world standards?
Yeah, I think, well, I think it's all tied together, right? I mean, I think that if you look at why the average lifespan is 66 compared to the region, and compared to other high income countries. When you compare it to other high income countries, you're losing a little, just shy of a decade, right? And the way to do that with averages is you look at, well, what is killing people before that age? What are the killers of people in the prime of their life, in their 30s, 40s, 50s, 60s? and it's all the things we just mentioned. It's non-communicable diseases, which include, by the way, accidental and intentional death, right? So trauma, and so which usually the number one cause of trauma is accidental, and it's motor vehicle, right? So it's road traffic accidents and deaths due to that. Number two is suicide, usually for trauma, and then obviously much lower but more public is homicide and kind of other kind of criminal causes of traumatic death. But the two biggest ones are accidental, so road safety and suicide, and so those are important. The cardiac disease, that's the number one killer. I mean, pretty much every high income country, the number one killer is cardiovascular disease. It's just happening a lot more at a lot higher rates in Guyana right now than it is in other high income countries. And I think that's because it's a little unfair. A lot of the other high income countries have been high income countries for a century. You guys are new kids on the block when it comes to high income countries. So you don't have a high income country's healthcare system yet. And so some of the interventions that prevent some of those deaths aren't readily available countrywide yet. And I think that's something that, like I said, when you're building the tertiary system and the primary care system, you got to do it at the same time. Because it's great to have diabetes prevention and hypertension control and everything, but for the person that's having their heart attack today, we want to make sure they can get to definitive care and not lose their life from that heart attack. And so I think you've got to do both and work on both. And I think that the nice thing about working in Guyana is because the population is sub 1 million people, a lot of those averages and statistics with interventions can change pretty quickly, right? Like it's not a denominator of, like we work in Southern India. Southern India has 300 million people in it. That's the entire population of my country in the area that I work in India. It's harder to move the needle there. It's harder to see progress. So I'm encouraged by that. I think that in Guyana we have the opportunity to move some of these statistics. And one of the things that we're discussing with the president's team right now is a cardiovascular program that would cut cardiovascular disease over the next 5 years by 40%. And that's ambitious and audacious, but we want to be ambitious. The Guyana cardiologists want to be ambitious. When we talk to them about this, they're excited about it. Everyone's excited about the potential here. We just need to activate it and really get moving. But to your point, the community center model, this is something that we're looking at Northwell. Bringing things back to the community, making it incentivizing, even in our own employee base, incentivizing people to walk around more, to do steps. We actually are in the middle right now of a step challenge where every employee has the opportunity to join a team of 5 people, and we're all competing for the next 6 weeks. Who can get the most steps, right? Who gets the most steps in? So like if I've got to go across the street to meet with someone at another building, I walk now because I want to get my steps in so I can beat the other teams. It's a competition. But incentivizing cardiovascular care, incentivizing activity, incentivizing social activities. A lot of people are spending a lot of time scrolling on their phones. It's a loneliness epidemic. Our previous Surgeon General called it. These are all things. The community center can fix a lot of that because it engages people, it prevents them from being lonely, and it gets them active and out of the house. And that's all of those things are really vitally important.
Yeah. Dr. Tari.
Okay. Yeah. Okay. Thank you, Dr. Pena. I just want to ask you a major problem in Guyana. I think it related to heart or stroke or diabetes is alcoholism. Drinking. It's not surprising to see the form that make the most money in Guyana, those dealing with alcohol alcohol. So, drinking is widespread. Alcoholism is a major problem. It leads to other problems like suicide and domestic violence, etc. Have you? Is there any program to deal with this? Because it's a real. Because most people think, including policymakers, they don't want to deal with this thing seriously. That's my view, and. But I think that the social fabric of the society is being broken because of the prevalence of alcohol. drinking, heavy alcohol drinking and alcoholism in Guyana. What are your thoughts on that?
Yeah, I mean, and again, I don't want to give Guyana a pass here, but this is a problem in almost every country that we work in. When we ask ministers of health around the world, what are their biggest headaches? What do they want to deal with? It's mental health and substance abuse. Everyone says it. It's the unifying factor in, doesn't matter, high income, low income country, doesn't matter. Nobody has a great solution for mental health and substance abuse. That being said, we are working with the ministry. We actually, while we were in April, while we were announcing the Subraj gift, we actually brought down the first addiction psychiatrist to the country. He now works at Northwell. We recently hired him, and he's talking about creating a subspecialty fellowship in addiction medicine for the graduates of a psychiatry program, so we could have addiction specialists that are Guyanese working in Guyana. We're also working with the existing the ministry's mental health lead and GPHC psychiatry to improve access to substance abuse programs. This is another thing. It can't be just in the tertiary setting. This is something that's widespread and needs to be in the primary care setting. And then recognizing that alcohol use is a symptom, right? Like alcohol use is a problem, but it's also the symptom of something else, right? And the symptom can be loneliness or social disengagement, whatever it is. But kind of things that engage the community more, number one, will identify those folks, hopefully, before they hurt themselves or hurt someone else. And then making sure there's pathways to treatment. And some of those treatments need to be community-based. And part of our Department of Psychiatry's relationship with the ministry and with GPHC is implementing MHGAP, which is a program released by the World Health Organization to empower primary care providers and community health workers to do basic management of anxiety, depression, and substance abuse. And so we've got to bring it down to the ground level. And then there also needs to be referral pathways for when a community health worker is not going to want to deal with anxiety, depression, or substance abuse if they feel like when somebody is too much for them to handle, they have no resources. They can't turn to someone and say, hey, what do I do? And so creating those pathways, making sure they're known, and making sure that community health worker or primary care doctor feels empowered that when there's a problem, they have someone at the ministry or at Northwell that they can call and say, hey, I need help managing this person. I don't know what to do with this person. Having those lifelines is vitally important, and I think will lead to the success of the program. But we're excited. That's a conversation that's also happening right now. And we're actually, believe it or not, I found it very useful. We tie it, because you're right that there is a little stigma around those diseases, right? So we tie it to brain health, and we tie it to the stroke care that we want to do. And we say, this is just human brain health. So we don't want you to have strokes. We don't want you to be depressed or anxious. And we don't want you to use substances to the point where you're impaired. And that's all around the human brain. And when you turn it into like kind of a brain science problem, you remove a little bit of the stigma, because you've got the neurologists and the neurosurgeons and the psychiatrists all sitting in a room together thinking about the whole brain. So that's been really helpful. And then I think the only thing that I would like to do more of as part of that initiative is, part of this is what we've done in the States is we've gone to the employers. We've gone to people that are employing people and saying, you should provide these services for your employees, that having wellness amongst your employee base will make your company more productive. And Northwell will partner with you to show you how we do it. We're the largest employer in New York State. So we do this now between New York and Connecticut, we have 104,000 employees. We do this for our employees. So we have the playbook. We know how to do this, and we can work with employers on how to make that a choice for their employees as well.
Mm-hmm. Thank you. Other question, the ministry has embarked on telemedicine in various parts of the country. Have you had a chance to assess this and or have any views on it? Are you collaborating with them on this initiative?
I don't want to take credit for anything they've already done. So collaborate is that we are aware of it and we are helping support it. We are, and everything we do I don't like to come down. I don't like to do things as Northwell in a silo. So when we do an initiative or a project, I want to make sure the doctors that are working in the country know we're doing it. The Minister of Health knows we're doing it. Everyone thinks it's a vital part of healthcare development. So certainly we're aware of the ministry's telemedicine initiatives. I've met with the CEO of 19 Labs, which is the subcontractor that's running this out, a guy named Ram Fish, who's a great guy, very, very, very skilled and knows his stuff when it comes to telemedicine. We've been thinking about for this is how do we create kind of a more robust telemedicine service. We want to take what the ministry's done and kind of amplify it, make it bigger. We want to make it more like there's we think about an acute care command center. So and the ministry's already kind of heading this way in terms of they've allocated space and they want to build a command center, but we want to integrate telemedicine into that command center. Because sometimes you call for a patient transfer from Lethem, for instance, and the real answer is you don't need the patient to move. You just need someone who's a specialist to give an opinion about that patient and help manage that patient remotely. And so we want the people that determine whether you get medevaced or whether there's a telemedicine solution to be the same people and to be working in the same command center, so that if the care can be delivered immediately where the patient lives, we do that. And so that integration is still to be done. But what they've accomplished so far, I tell people when I'm at the World Economic Forum, and I'm actually heading to the World Health Assembly next week in Geneva, and people talk about rural medicine and how hard rural medicine is. And I tell people, the Minister of Health in Guyana is dropping Starlinks into the Amazon and doing remote sessions with community health workers, and it's doable. Technology has made the world much smaller. It's just how do we deploy it and how do we use it so it maximizes the value to the citizens and the people that need the help.
Let me ask you this final question before we move on to Professor Boodoo. We don't have much more time, but if you can give me a quick response, what role do you see AI in medical advancement?
I'll give you two examples of where I think AI is going to help, and I'm going to be very brief. I think for workforce issues, AI has the potential to make nurses and doctors not only more efficient. All the administrators talk about efficiency. It will actually bring the joy of being in medicine back to medicine, because the things that we don't like about medicine, AI can fix. The needing to spend time, they're rolling out an EMR, but needing to spend time documenting what you've done for a patient instead of spending time with the patient. Decision tools that'll help doctors and nurses provide better care, capture data, all of those things that right now are being done manually by people. We don't have enough people in healthcare. No matter which country you're talking about, we don't have enough people. So having AI assist the humans in taking care of people is going to be very valuable. The second example I'll give you of that is that remote monitoring or that remote patient, right? You've got a community health worker taking care of a patient in region 6, we'll say. Having that person be able to use AI to, for instance, use ultrasound to capture images, instead of needing to be trained on how to do ultrasounds of the heart, the way AI is developing an ultrasound now, all they're going to have to do is just move the ultrasound probe over the chest like this, in like a lawnmower fashion, like they're mowing the lawn on the patient's chest. And the AI is going to reconstruct all the images that were captured and present them to the cardiologist who's sitting in Georgetown. That's going to revolutionize how we do diagnostics in medicine. And as a country that's really hurting for ultrasound technologists, that could solve some of that issue. So I'm excited about it. It's not going to replace humans, though. Like people that are worried it's going to replace doctors, not going to do it.
Okay, thank you, Doc. Professor Boodoo,
Dr. Pena,
over to you.
My view is Guyana is in a unique position not to reproduce health problems that arose in fact, in other high-income countries. And I think the initiative that you are doing with the government, I think, is in the right direction. But I think that we have to be very careful that we don't have excessive expectations, because you have only started there, what, 3 years ago or so? And I know people have been trying to compare uh, nurses to patient ratio or doctors to patient ratio with Guyana and the US and other places. And of course, those figures will never come out correct, right?
Right.
It will take a long time. But the kinds of initiatives you guys are doing, right, will go a long way in preventing Guyana from actually inheriting those problems. What are the biggest challenges you are facing in implementing this program in Guyana?
Workforce.
Mhm.
And number three is also workforce.
Mhm.
The government is looking in any way possible. If they could build nurses right now and make AI robotic nurses, they probably would.
Mhm.
I think they can't train them fast enough. They can't recruit them fast enough. They can't hire them fast enough. And then retention of nurses. The problem is that even within the country, there are areas of the private sector that even if the government raises the salaries, the private
Mhm.
sector can pay that in a month. And so you're
Mhm.
never going to compete with the private sector just on salary alone. It has to be the conditions, the working conditions, the opportunities for
Mhm.
promotion and academics are what
Mhm.
keep people in a public system. And so we're working on that. Our retention programs, when we
Mhm.
first came in, our chief nursing officer, who's Guyanese, by the way, Lynette Wilford, who manages the nurses at our 28 hospitals, our 20,000 nurses.
Mhm.
She's in charge of all of them. She's Guyanese, and she's come to Guyana. She's worked and consulted on this. And they wanted, when we first started talking, we were talking about subspecialty nurse training. And she said to me very honestly, she said, Eric, I don't want to train subspecialty nurses yet because they're going to leave and they're going to go to Canada and they're going to go to the United
Mhm.
States. And I really want to try and fix the retention issue as priority number one. And that is still priority number one. And look, this is a problem in every country I go to. This is a problem. Everyone's dealing with workforce shortages. And you're right. It's not going to happen overnight. It's not going to happen quickly, but it has to happen. And we can't lose hope. It has to be slow, steady pressure towards getting up to safe ratios. And I agree with you. The ratio comparisons, they do that in New York City, and it's like,
Mhm.
great, okay, what are we going to do? Like if there's we're not going to close the emergency department because we don't have enough nurses. Like I'm an ER doc. We deal with it. Whatever happens, we have to deal with it. And so there's sort of that part of it where for the next couple of years, we have to do everything we can to retain, attract, and train. But there's also going to just be shortages, and we're going to have to deal with those as best we can to keep people as safe as possible. And that's what we're thinking about with communication and telemedicine and AI, all these other technologies to try and keep people safe.
But I think the best measure, though, is
Professor,
outcome. Rather than these numbers,
Yeah,
outcome, I think, is the
outcome
best
measures. Yeah, because
is
the
the
patient
best
doesn't
measure.
care how many nurses there are. The patient just says,
Right.
"Am I more likely to die of a heart attack or not in
Yes.
this hospital?" That's what you're
all right.
absolutely
Yes. Okay, Tara.
All right. Dr. Ganga, your last observation and question.
Yes, I'm happy to learn about emphasis on administration and access. But most importantly, or more importantly, is your holistic treatment. And I'm happy to learn about the linking of the what's observed at the patient's level, their condition or their human condition, and brain science. But we also have food science, and that works at the cellular level with cancer.
yes.
So things like sugar and seed oils and the hereditary conditions, those factors needs education. So while we are divorced medicine from food, they are two separate tracks. We need to integrate them just like you did with the brain through the stomach
Yeah.
because that plays an important role. What I'd like to learn today from you, you're the AI specialist for me and our audience, is how we manage inflammation, not inflation, that's economics. That's my area. But inflammation management is vital to overall health. I've checked this indirectly, personally, and with other people. What's your thoughts on inflammation management?
Well, I think a lot of the things that we've been talking about, diabetes, one of the reasons why diabetes is such a killer of people is because having excess sugar in your bloodstream is very inflammatory. It causes inflammation of your arteries and the blood vessels going to your brain and your heart. It hardens them, it narrows them. You're absolutely right. Stress causes inflammation. So the mental health that we don't get to just put it in a box and put it away. Mental health and anxiety and depression, when you look at those diseases, they lead to worse outcomes in other medical diseases. Someone with depression is less likely to recover after heart surgery or hip surgery than somebody who's not depressed. All other things being equal. So there's certainly a component of this where, and some of it is we have this whole food is health initiative at Northwell, and we've actually changed our hospital food. We actually we about 7 years ago, we got rid of all of our unhealthy foods in our hospitals. We hired Michelin starred chefs at each hospital to make our menus, to buy whole foods from single source producers to make our hospital food better, because we can't tell people to eat healthy and then serve them crap in the hospitals. It has to be that we're doing it. We're preaching we're doing what we preach. And so this whole concept and the we're still learning. We're very early on how inflammatory some foods are. But some of the stuff we know, like saturated fats, trans fats, all these things, we know this. We know that these are bad for us. And so getting them out of foods and getting back to kind of whole food, fruit, vegetable, good sourced meat cooking is going to be one of the major building blocks of building a healthier society. And it's absolutely got to be part of Guyana's future.
Yes, for those who are listening, the food services at colleges and universities would benefit a great deal from your advice. So thank you for that change that you made and you initiated at the hospital. That's remarkable. Thank you very much.
I always say our CEO says, we operate the largest restaurant in New York City. If you look at all the meals that we have to serve every day, we do way more tables than any restaurant in New York.
Yeah.
All right, thank you. Just is there any collaboration between Northwell and Guyana in the area of cancer treatment?
Yes. So we're in the middle of discussions right now with the government about launching a major 5-year initiative on cancer diagnosis and prevention, and targeting the 3 biggest killers right now, which is cervical, breast, and colorectal, being the 3. But honestly, the system that you build works for all of them, but specifically targeting those as numbers that we want to see reduced. We can detect all 3 of those cancers before they become cancer. We can prevent those with vaccinations. So we have to do a better job of that, and that's something that the health system is eager to partner with the government and the private sector on. That's something we've engaged the private sector in collaboration. I'm really hoping that we'll have an announcement about that initiative in the next couple of months as we continue to develop it. But we're in talks. We're starting it like everything. We kind of build the plane as we fly. We're starting it anyways. We're starting the conversations. But I would love to get a private sector sponsor to really accelerate what we're doing and get it done much quicker.
All right, thank you very much, Dr. Pena. Most informal conversation we had with you. I pass you over to our host, Shamiza.
Thank you, Dr. Tara. Thank you, Dr. Ganga and Professor Puru. Thank you for everything. We do not have any questions. We have a lot of, suggestions and input. So thank you to our viewers for their input on tonight's program. We appreciate it. This question, Dr. Pena, is coming directly from me. Guyana has consistently been on the World Health Organization list of countries for suicide. Consistently, we have been at the top there. Your Northwell and Guyana, is there resources and a plan in place, let's say, for example, for the next 5 years, of what plan is there to help tackle this issue for Guyana?
Yeah, the short answer is yes. We recognize, and this is a priority for the Minister of Health. It's a priority for when I spoke with President Ali. This is a priority for him, and it's certainly a priority for the health system. Mental health is health. It's no different than anything else, and there is an epidemic of suicidality. Guyana, as of the last statistic kept, has the second highest suicide rate per capita in the world, second only to Sri Lanka. And I think that there's a lot of things that can be done. I think there's a lot of things that have already been done. I think when I first started working in Guyana, there was one psychiatrist in the country in the public system. There's now 7 or 8 times. There's more, and there's more in the pipeline getting trained. But I think we need to bring. And the ministry has done this to a certain extent, but I'd like to accelerate it, bring mental health more to the community. We also need better education about locking away lethal forms of suicide attempts. The one of the things that's concerning about Guyana's suicidality is the access to lethal means. So the pesticides that are in the country are extremely lethal. You can't, there's a lot of people that that I take care of as an emergency doctor in New York that take pills and realize after they've taken the pills they don't want to die, and they come to the ER and we can save them. A lot of the ingestions in the United States are non-lethal, right? I can give them treatment and they survive, or I just support them and they survive. In Guyana, a lot of the chosen substances for ingestion, by the time they decide they don't want to die, it's too late. They've already ingested something that's lethal. And so there's a huge public health initiative that we're working on with the ministry to try and inform people, educate people, lock up the poisons, lock up firearms, and all of those lethal means of suicide, so that people have the ability to change their minds after they've already taken a step to hurt themselves. That's, I think, the tip of the iceberg, and then getting farther into wellness. A wellness model, earlier treatment of anxiety and depression, comorbid substance abuse, like you talk about, all of those things. I think the symptom is suicide. The cause is everything else I just mentioned.
Perfect. Well said. Is Northwell working on any programs with Guyana for domestic abuse, which is another big issue in our country?
Yes. So not directly as of yet. It's definitely something that we're interested in. I think the primary care platform that we're helping build with the education into the community around mental health will impact that. But we have not been asked nor designed a specific program to impact it. We recognize it as a problem. It's a problem everywhere. But it's certainly something that's we'd love to engage on it. We'd love to figure out how we can be helpful in that.
Perfect. And I would love to have discussions. I'm the founder of Safari for Hope, which is a program that we work with the victims of domestic abuse. So if you like, we can talk a little bit more on how we can make this possible. The cost of prescription drugs and medical care in Guyana, especially things like x-rays and different services in Guyana medically, are very expensive. Is there a plan in place to help with those prescription drugs and other medical issues that we're having currently?
Yeah, I mean, I think the plan is to get as much on the public formulary as possible, so that it's at no cost to the citizen. That's Northwell's plan. And part of that is through working with Ministry of Procurement to make sure that it's accessible. There have been issues. We have actually encountered multiple issues where people in GPHC, in the ministry, are trying to do the right thing and buy things in bulk for the country. And we've seen vendors, international vendors, that don't want to sell because they think Guyana is too small of a market. It doesn't make sense for them to learn the local regulatory and get approval to do it because it's just not worth the volume of sales that they're going to sell. And that's one of the ways that Northwell's tried to be helpful. We actually just helped GPHC procure new surgical tables for their ORs. because the company wouldn't sell them to them. So they're selling them through Northwell. Northwell is going to be a pass-through because we have a very good relationship with a lot of these supply companies and pharmaceutical companies, and they need to understand that Guyana is our friend, and we want to treat our friends well. And so a lot of times it just takes an introduction from whoever runs our account at the health system to say, hey, we'd really like you to talk to these guys. They want to buy some surgical tables from you. So same thing. I think it's about the public system having the support and the supplies so that the people that don't want to use the private sector for healthcare don't have to. It's only the ones that want to opt out of the public system and do something because it's faster or they think it's better. They can opt to do that, but it shouldn't be a forced choice. There should be an option in the public system that allows you to get this.
Perfect. Beautifully said. I do want to thank you. I will now ask you for your closing remarks as we end this program.
I'm very excited. I think that Guyana is at a pivotal moment, as someone else on the panel said, in its development. It's a recent high-income country. There are lots of competing priorities, and right now there aren't enough funds that the government has at its disposal to address every single priority. And so I wouldn't want to be in the government right now. It's a tough decision. You've got to make tough choices, but the trend line is heading towards prosperity, progress, health, and safety. And that's a great direction to be heading in a world where there aren't a lot of countries heading in that direction very quickly. There's a lot more in the news heading this way. And so I'm really excited and energized. Every time I visit Guyana, I get very energized and very excited about what's getting done, what the progress is. And everyone I've met that's working on this is deeply passionate about it. One of the things that's the side effect of having a lot of kind of poaching of healthcare workers to other countries is those that are still there are really passionate. They believe that this is a mission of theirs to improve the healthcare. And so I feel honored to know them and to work with them and help support them. And I'm really excited for the next 5 years. I think it's going to be really exciting.
Well, we know that you're very passionate about what you're doing. And I know as a Guyanese, we're proud to have you in collaboration with Guyana to help our people. So thank you very much for everything that you do. Thank you to our panel. Thank you to my moderator, Dr. Tara, and to all our viewers. I also want to say special congratulations to the entire team of the Guyana Dialogue. It has been 3 years of bringing you exciting information for the PPP government in Guyana, and we're so grateful for your support and your love. Until next time, I am your host, Shamiza Ali, and this is the Guyana Dialogue. Good evening, everyone.
Good evening.
Good evening.
Thank you very much.